Hi everyone, my name is Nathan Blue. I'm a maternal fetal medicine or high risk obstetrician here at the University of Utah, and I'm really excited to present this work to you today. Thanks so much for sharing your attention. That's me in the lower left hand corner. Since you can't see me as I talk, you can find me on Twitter at NatyBlue, and if you see a QR code in the presentation, on all the slides, it's the same QR code. It's just a link to the collection of references that I use during the presentation. So feel free to open that up anytime you see it. Fetal growth restriction is a condition where a fetus doesn't meet its growth potential, and it's important to recognize prenatally because it is a leading risk factor for preventable stillbirth. Our available strategies perform poorly, but it's important to get right because in the best case scenario, we can recognize it and prevent a stillbirth that otherwise would have occurred. But in the worst case scenario, we either over intervene in healthy fetuses or we miss sick fetuses and otherwise preventable stillbirths take place. Fetal growth restriction is typically diagnosed using a curve like this. This is a widely used curve published by Frank Hadlock in 1991. The way it goes is that an ultrasound is used to measure a fetus's weight, and then that weight is plotted along the curve here. And if at that given gestational age it falls below the 10th percentile, then fetal growth restriction is diagnosed. This project got started during a previous analysis, and we did an analysis by sex and found that the Hadlock Fetal Growth Standard, which I just mentioned, diagnoses fetal growth restriction more than twice as often, or I should say nearly twice as often in female fetuses in black here as in male fetuses, which are in gray. Now that was striking, but it's possible, I guess, that female fetuses have more complications. Except when we analyzed the rate of complications by sex, we found the opposite, that instead of female fetuses experiencing more complications from fetal growth restriction, actually male fetuses experienced higher rates of complication. And so this was a clear signal that something is wrong here, that the increased rate of diagnosis of fetal growth restriction in female fetuses is an overdiagnosis. Now, an important thing to know about the Hadlock Standard, which I just mentioned, is that it is sex neutral. That is to say, it generated a curve for all fetuses irrespective of sex, which makes sense because in 1991, ultrasound technology didn't really allow for consistent and easy identification of fetal genitalia. There are other problems with the Hadlock curve, such as that it's from a very homogeneous white group of about 390 women in Houston, but that's for another presentation. The finding that female and male fetuses are different sizes at the same gestational age is actually old news. It's very well established. In fact, this is a figure from 2003 showing birth weights by sex at different gestational ages. And you can see clearly that female fetuses, represented by the solid lines, are smaller at virtually all gestational ages than male fetuses. So let's dig into then how this reflects in current practice. Well, in modern practice, this is accounted for. In fact, it's established well enough that all birth weight and neonatal growth charts, here are three relatively newer curves on the left. These each account for fetal sex, and they publish tables and curves for male separately from female fetuses. Now, we could give a pass to Frank Hadlock in 1991, but it does not add up that more recent fetal growth standards specifically designed for prenatal application do not account for fetal sex, even though this is known. So what gives? So this is what we set out to do. We decided to assess differences in fetal growth by sex, and then to use that information to derive a sex-specific fetal growth standard. We also wanted to assess or at least preliminarily explore the implications of applying a sex-neutral versus a sex-specific growth standard. We utilized the prospective observational cohort, which was the New Mom to Be study. This took place across 8 United States centers and included just over 10,000 first-time pregnant participants. These participants underwent a fetal size assessment at 4 time points, 3 of which occurred during pregnancy, shown here, and then the last one at birth. For the derivation of the sex-specific curve, we limited the cohort to low-risk pregnancies that did not have known risk factors for aberrant fetal growth, since we're trying to define and describe what is normal rather than what is likely to be abnormal. A few definitions that we use: small for gestational age, which is frequently a surrogate for the label of fetal growth restriction, was a fetal weight or a newborn size less than the 10th percentile for gestational age. And large for gestational age is a size greater than the 90th percentile. These are our basic results, the basic background characteristics of the cohort. You can see that age and BMI are unremarkable. There is a representation from different race and ethnicity groups, though not perfectly representative of the United States. The mean gestational age at delivery was the latter part of the 39th week. The birth weight averaging 3 1/3 kilograms, and 49% of newborns were female. This is a scatter plot illustrating the data points from the different time points in pregnancy. We really just utilized fetal assessments starting at visit 2, which started just before 16 weeks, since that's the earliest that fetal weight is meaningfully described clinically. You can see that in blue is our data points from visit 2, in gray from visit 3, these are ultrasounds, and then in black, the birth weights. There's a gap between the visit 3 and the birth weight assessments because most of these participants had their research ultrasounds before 34 weeks. These are the smoothed curves from the data that plot the existing or the known Hadlock standard, as well as the male and female specific standards derived from our data. You can see that the Hadlock standard expects fetuses to be larger than both the female and male standards from this cohort. And you can also see that the male fetuses in the dashed line are larger than the female fetuses in the dotted line. And that appears to be a small difference, but it is statistically significant. And if you're wondering whether such a visibly small difference can make a difference clinically, I will show you. So here's what we had shown before, that the Hadlock standard diagnoses smallness, here considered SGA, at nearly twice the rate in female fetuses in the light gray as in male fetuses in the dark gray. When we applied our newly derived sex-specific standard to the cohort, that resolved the disparity. Looking at large for gestational age, we find a similar phenomenon. The Hadlock standard diagnoses more males as being too large than females in the light gray. That's a statistically significant difference. And applying the sex-specific standard resolves the disparity, although it does diagnose more fetuses or newborns overall as being large. So this illustrates how those labels actually matter with respect to fetal sex. So you can see here, looking at the female newborns, that those that are considered to be normally grown by both sex-neutral and sex-specific standards experience morbidity at a rate of about 9%. Now, those who were considered small by the Hadlock Standard, but then are reclassified as normal by the sex-specific standard, they actually have a lower rate of morbidity than the baseline group. And this is really just to emphasize that these are being misdiagnosed as high risk when in fact they are a very low risk group. And that pattern is not exactly the same in the male newborns. Those reclassified from being small to being considered normal by the sex-specific standard have a comparable rate of morbidity as the baseline risk group. But the differences here between the sexes show that female fetuses are disproportionately affected. So in conclusion, firstly, fetal growth differs by sex. This is not new, but we again found it to be true in our cohort. Secondly, the sex-neutral standards, such as the Hadlock Standard, overdiagnose fetal growth restriction in female fetuses, and this disproportionately affects female fetuses over male fetuses. Our sex-specific standard needs to be validated before use. However, I just want to suggest that as we move forward in validating and testing this curve, that our benchmark is not only prediction of morbidity, but perhaps that resolving the disparity in overdiagnosis is important in and of itself. And that's because here is just the example of the intensive surveillance regimen that pregnant people who are diagnosed with fetal growth restriction undergo. They undergo multiple ultrasounds for fetal growth as well as umbilical artery Doppler. They undergo weekly fetal heart rate monitoring and frequently delivery before 39 weeks, even when all of the monitoring has been reassuring. Now, receiving that label of fetal growth restriction, not to mention the monitoring and early delivery, really represents meaningful and measurable stress and harm for this group, and it's not right that that disproportionately affects female fetuses. And I love memes, so this one represents, I think, what sex-neutral standards do. So here we are in the top panel, screening for fetal growth restriction, trying to do a good thing. We apply a sex-neutral standard, which is the standard of care, and think we're doing a good thing, but then we end up disproportionately exposing female fetuses to iatrogenic harm. And so this is a clear opportunity for improvement. This is the end of my presentation. I want to thank the large group of mentors sort of across domains here at the University of Utah who have been supportive to me during my nearly 4 years on the WRHR, and who continue to support me going forward. Thanks so much.